Okay, we are going to start the next session. This is also the joint session with Heart Failure Association. And I would like to call upon Ahmed El Damati. Ahmed, please, would you please be so kind to talk about one of the most frightening Sorry. Let's wait for the minute so the people can settle, and then we will go ahead. Two, 3 minutes, huh?
تمام كده اسيبه مش هيقع اكيد على ضمانتك ماشي.
If you are ready, we can start. So the first talk is about risk stratification for sudden cardiac death. As we all know, this is one of the toughest issues in cardiology, but also in heart failure. And the talk will be delivered by Ayman Makerashan. Please.
First of all, I'd like to thank the organizing committee for the kind invitation to join this outstanding gathering, CardioEgypt, this year. My talk is about risk stratification of sudden cardiac death in heart failure. Of all presentation of cardiovascular disease, sudden cardiac death is the most challenging and fear. It accounts for millions of deaths worldwide every year. It could strike without any warning in even apparently healthy population. Sudden cardiac death is defined as death from unexpected circulatory arrest occurring within an hour of the onset of symptoms or during sleep. Is triggered mostly by a rhythmic event, although pulseless electrical activity has been recently reported. Despite major investment, the prognosis of hospital cardiac arrest continued to remain dismal, with the highest reported overall 30-day survival being 13. The causes of sudden cardiac death varies among group of ages. In population less than 35 years old, the primary electrical disease like long QT syndrome, Brugada, hypertrophic and dilated cardiomyopathy predominate, while in patients with more than 35 years old, coronary artery disease represents around half of the percentage of sudden cardiac death, while in elderly population, structural heart disease like valvular heart disease, heart failure, and coronary heart disease predominate. In general population, only half of cases are diagnosed with heart disease before the event. The annual incidence is estimated between 30 and 125 per 100,000 persons per year. Sudden cardiac death is the most likely cause of death, representing around 10 to 15 of all deaths. In heart failure patient before disease-modifying therapy, the incidence was around 20%. With current treatment and electrical therapy, the incidence has decreased to about only 3%. Currently, sudden cardiac death accounts for about 40 to 45% of all deaths in HFA patients. It is higher in patients with milder symptoms, NIA class 2 and 3. Limited data are available about sudden cardiac death in patients with HFA. However, recent trial reported that sudden cardiac death occur in around 20% of patients with HFA. The mechanism of sudden cardiac death is a little bit complex. It requires the chance of interaction between transient events like PVCs and presence of pathological substrates, which could be scar in ischemic heart failure or patches of fibrosis in non-ischemic, and this is result in electrical instability in form of ventricular arrhythmia, VT or VF. In patients with systolic dysfunction after MI, non-arrhythmic sudden cardiac death frequently occurs during the first 4 to 6 weeks. It seems that the proportion of arrhythmic and non-arrhythmic sudden cardiac death become equivalent around 1 month after acute coronary syndrome. And now I'm going to shift to the main item of my topic, which is risk stratification. And although many risk factors have been identified for sudden cardiac death in HFrEF patients, risk stratification to identify who are eligible or candidates for primary prevention with ICD remains challenging. Those are the points, and I'm trying to discuss every point separately and briefly. And those are the latest guidelines for ICD implantation in patients with heart failure. In ischemic heart failure, they denote that in patients with function less than 35. هو في خير. In patients with function less than 35, despite more than or 3 months of optimum medical therapy, they can receive ICD implantation according to guidelines. We will notice that in patients with non-ischemic heart failure, it was downgraded or softened to class 2A, and this was after results of Danish trial, in comparison with guidelines which was published in 2016. In recent guidelines, EF is widely used to identify candidates for primary prevention with ICD with well-recognized limitation, and I'll discuss it soon. In a biggest study for around 2,000 patients with sudden cardiac death, only 20% have EF less than 35. And around those guidelines, many questions to be addressed. First question, does a lot of trials exist supporting those guidelines? And the answer is, unfortunately, since the sudden cardiac death HF trial, which was published in 2005, no large trial in ischemic heart failure patient supporting the use of ICD. So those guidelines seems to be relatively outdated nowadays. The second question is, do the majority of cases of sudden cardiac death occur with EF less than 35? The answer is no, because most of cases occur in patients with normal function or mildly reduced EF. Could EF improve with time beyond 3 months? I could consider that EF is neither sensitive nor specific for detection the eligible people for ICD implantation, because the guidelines stated that 3 months is enough to detect people who are candidates. But post-hoc analysis in other trials for using ARNI, for example, resulted in improvement in EF after 6 months up to 30%, and after 12 months, this proportion was duplicated to 60%. So it seems very premature to detect 3 months only to measure EF, because eligible patients in those category will become ineligible after improvement of EF. The same for NIHA class, because of using ARNI and AGL2 inhibitor will transfer the patient for NIHA class 2 to NIHA class 1, and the guidelines emphasize that people or patients with functional class 1 will not get any benefit. So I think with those patients, they will no longer meeting the criteria to be a candidate for ICD implantation. Does QRS duration matter? In MADIT-2 trial, there was no mortality significant difference regarding patients with small QRS complex. So perhaps we are in need to reclassify those patients with narrow QRS in high risk categories to choose which patient will get benefit. Why there is a need for more accurate selection for patients with what get real benefit from ICD? Number one is to reduce patient risk associated with implantation, like dislodgement, infection, and others. Improve patient psychology, stress, for fear of inappropriate shock, fear of trials, and so on. Cost saving not only for the pacemaker itself, but also for the follow-up clinic and programming. How would we improve patient selection? There is emerging evidence of patient characteristic imaging biomarkers and others that may aid further certification of those most likely to give benefit of primary prevention. Number one, ECG marker. I try to go rapidly through details. ECG like microvolt T-wave alternance, QRS fragmentation, QRS duration, and ventricular rate potential. Microvolt T-wave alternance was found to be strongest predictor of arrhythmic events in ischemic cardiomyopathy. The utility of microwave T-wave alternance remains unclear. ECG score was developed. Those are the elements of ECG score: heart rate more than 75, QRST angle, LVH, corrected QT interval, T peak to T end, and delay QRS transition. Speckle echocardiography could provide an indirect evaluation for systolic function. Mechanical dispersion also was associated to arrhythmic risk in both ischemic and non-ischemic origin. Cardiac MRI, late gadolinium enhancement was a powerful predictor for ventricular tachyarrhythmia, and particularly in patients with EF30 or less. T1 mapping is the latest method for assessment of diffuse fibrosis. Biomarkers elevated NT-proBNP has been shown to increase the likelihood of sudden cardiac death. Additional biomarkers as ST2 and galactin may play a role in biomarker risk stratification. Autonomic function tests like heart rate variability and heart rate turbulence. EPS study, especially in patients with EF less than 43 to 40 days post-MI, is the focus of concern nowadays. What are we waiting for? We are in need to move beyond the EF cutoff method to select patients eligible for ICD, creating risk model using cardiac MRI, biomarkers, EPS, and others. In the future, it may be able to immediately notify the nearest emergency service in cases of sustained ventricular arrhythmia. The future of non-invasive monitoring devices, which include photopulsosomography technology and wrist-worn devices, shown promise. This is a device. It is time for a trial to determine whether today primary prevention ICD implantation would still convey any prognostic benefit in ischemic and non-ischemic HFA patient, in patients with narrow QRS duration in current era of disease-modifying therapy. Such a trial could also identify a more refined risk certification system rather than EF and NEHA classification. And finally, as cardiologists, we have to remember that we are trying to save life, not only inside the hospital, but outside the hospital. We have to try to increase the availability of external defibrillator, encourage using it, and learn people how to use it. Thank you so much for your kind attention. Any question?
Thank you so much, Professor Ayman, for this elegant presentation. Any questions from the floor? Yeah. So, thank you, Dr. Ayman. So, for the sake of time, I'd like to introduce the next speaker, Professor Lamia Allam, Professor of Cardiology in Shams University. And she's going to talk about the role of guideline-directed medical therapy. Do guideline-directed medical therapy prevent sudden death in heart failure or not? Dr. Lamia.
Good morning. First, I would like to thank the organizing committee for inviting me to attend the CardioEgypt Congress and having me among these elites in management of heart failure across the world, actually, and to give a talk about this interesting topic. Do guideline-directed medical therapy prevent sudden death in heart failure? As all we know, during the past decades, 3 decades, HFA have evolved from rapidly fatal disease to a chronic condition, requiring long-term team management in the past decade. But still, the sudden death is a major contributor for burden of all-cause mortality. And according to the American Heart Association Heart Disease and Stroke Statistics in 2003, they stated that 20% of patients dying within 1 year of initial diagnosis with heart failure, and more than 80%, 8 years mortality of deaths in patients with heart failure. And unfortunately, up to 50% of these deaths are suddenly and unexpected. That's why patients with heart failure has 6 to 9 times rate of sudden cardiac death of the general population. And this nice paper shows what is the causes of sudden death in heart failure. Most of the patients, sudden cardiac death is due to lethal ventricular arrhythmias, either tachycardia or fibrillation, due to the remodeling which occurs during heart failure, causing cardiac dilatation, scarring, fibrosis, which represent an initial substrate for induction of these ventricular arrhythmias. And that explains why even patients with not severe impaired ejection fraction may suffer from sudden cardiac death. The second cause is bradyarrhythmias or pulseless electrical activity, which occurs actually in more advanced stages of heart failure due to myocardial pump failure. And this paper published by Jordan et al. Shows this nice diagram, which explains the risk of sudden cardiac death in patients with heart failure. He said that in general population, there is a part of this population have a genetic predisposition for sudden death. And when they develop this patient heart failure, this risk become more due to the electrical abnormality which occurs during the process of heart failure. And this explains why some patients dying from myocardial failure and some patients dying from sudden cardiac death. And if they expose the environmental factors like electrolyte disturbance, drug ischemia, the risk become more and more for sudden cardiac death. Along the all years, heart failure medical therapy, especially in the last century, the medical therapy failed or shows its ineffective way to improve or prevent the sudden cardiac death until 19th, in the last part of the century, with the era of development of medications which started to act on the neurohormonal activity like ACE inhibitors or ARBs, beta blockers, and the era of ICDs. The risk of sudden cardiac death in heart failure patients changed over time among those patients. This nice paper published by Dr. Magdi Abdelhamid 4 years ago with his colleagues in the ECC, European Heart Journal, shows us this diagram, which shows all medications which have proven that they decrease or prevent the sudden cardiac death in patients with heart failure, including beta blockers, MRA, ARNIs, ACE inhibitors, and SGLT2I inhibitors. What about the beta blockers? This meta-analysis by Gaburi et al. Included 30 trials of studying beta blockers in prevention of sudden cardiac death versus placebo, shows us that beta blockers succeeded to decrease the risk of sudden cardiac death by 30%, the all cardiovascular deaths by 29%, and even all-cause mortality in patients with heart failure by 33%. What about the MRA, mineralocorticoid receptor antagonists? This meta-analysis published by Rosillo et al., including the 3 eminent trials in MRI versus placebo in prevention of sudden cardiac death in patients with HFrEF, shows that MRI has effect in decreasing the risk of sudden cardiac death by 23%. ACE inhibitors was the first drugs in these category of medications, shows efficacy in decrease all-cause mortality in patients with heart failure, but still its effect on the sudden cardiac death is still moderate until the combination which happens between neprilysin inhibitors and angiotensin receptor blockers, which shows superiority over the ARBs and ACE inhibitors in prevention of sudden cardiac death in paradigm heart failure. It shows that it is superior to prevent the death from cardiovascular causes, hospitalization, worsening heart failure, first hospitalization as primary endpoint, and even in the secondary endpoint, it's superior than enalapril in prevention of death from any cause in patients with heart failure. This is not the effect of ARNIs, but also improve heart failure. It shows that it is the medication who causes even reverse cardiac remodeling in patients with heart failure. It improves the echocardiographic parameters. It even improves the systolic ejection fraction in patients with heart failure. This trial shows that 1/3 of the patient included in this trial has an improved ejection fraction more than 35% by 6 months. And 2/3 of these patients has an improved ejection fraction by 12 months after initiation of ARNIs medications. What about SGLT2 inhibitors? This medication also shows its efficacy in reduction of sudden death in patients with HFA. In DABA heart failure, dapagliflozin significantly reduced the risk of sudden cardiac death by 26%. And even in EMBRA-reduced trial, dapagliflozin also significantly reduced the risk of cardiovascular death in this category of patients. And even this meta-analysis shows that this effect of SGLT2I inhibitor drugs decrease the risk of cardiovascular death and worsening of heart failure, regardless even the use of ARNIs. And this interesting paper published by Lee Hall et al. Shows that even these medications had an arrhythmogenic effect, direct arrhythmogenic effect. It reduced the risk of ventricular arrhythmias by 27% and the risk of progression or incidence of atrial fibrillation by 18% and even decrease embolic events, which is an interesting paper. I think it's need to be more studied if they have actual arrhythmogenic effect besides the remodeling effect in heart failure patients. Shan et al. Released this meta-analysis assessing the risk of sudden cardiac death in patients over the 19 years, including about 12 clinical trials, and shows that the rate of sudden cardiac death in patients with HFpEF declined by 44% over the past 2 decades. And this finding is associated with the cumulative benefit evidence of these medical therapies that I mentioned. They stated that the cumulative incidence of sudden death is approximately 1% by 3 months and 2% or less by 6 months among patients treated with ACE inhibitors, MRA, and beta blockers. And if we added ARNIs, these risks become reduced more, reaching to 1.7 by 6 months. And the cumulative effect of reducing the sudden cardiac death is 88% after 3 years. That's why in the recent guidelines, these medications becomes the class 1 indication in any patient with HFrEF. And even it's called the 4 pillars because of their efficacy on proof to reduce the sudden cardiac death in these patients. In the end of my discussion, I open this slide for discussion. Although we have a proven efficacy of these guidelines, directing medical therapy reduce mortality and morbidity, but remains an ongoing challenge for patient, clinician, and health system. Why? First, and most important, the adherence to targeted doses of this medication in real life, as mentioned in the trials. The ICD patients. Most of these trials didn't include the ICD patient or even include it in small parts, like Paradigm. It's included only 40% in these patients has an ICDs. Still, in these trials, the risk of sudden cardiac death is higher relatively compared with the ICD, as in the Shan et al. Meta-analysis shows that it is 8.8% over 3 years. And if we want to assess the role of ICD, I will leave this slide for my next presentation with my colleague. If we need to delay the implantation of ICD as a primary prevention, for how long should we wait before we decide to implant ICD as a primary prevention? Thank you.
Thanks, Prof. Dr. Lamia. It's a very interesting topic, and you presented very clearly in your scheduled time, which is very good. And I think you have a good preparation for the next speaker, Professor Dr. Muhammad Hassan. But before you leave, I want to ask if there is any question about this topic. What?
Full parallel is excellent for reduced ejection fraction, but we must insist on CKD screening. CKD screening is very important in this patient. CKD screening, if give ARNI, MRA, beta blocker, diuretic, so and so. CKD screening by imaging, grade of nephropathy, and by creatinine albumin ratio is very important. We must obey guidelines, but we should the efficacy and must note the side effect of these by routine follow-up of kidney of those patients.
I'd like to thank Professor Lamia for this elegant presentation. It is not easy to see an expert electrophysiologist like Lamia to say that guideline-directed medical therapy will prevent sudden death because she's implanting a lot of ICDs every day. So now, after the new data of guideline-directed medical therapy, you will wait, you will downgrade the recommendations according to the last EC guidelines, or what's you're doing in your daily practice?
Actually, Dr. Magdi, I believe that we still have a long period to decide to postpone ICD as a primary prevention in patients with HFA. And we need more trials, including patients with ICDs, to put the ICD head-to-head with the guideline-directed medical therapy. Until now, there is no guidelines, large randomized clinical trials over a long period of time to compare between ICD as a primary prevention and these medications in prevention of sudden cardiac death. It is just small trials, studied patients who have an ICD. Yes, this medication shows that these patients has a lower risk of ventricular arrhythmias, received less appropriate ICD shocks, but I think we should wait to decide. Even some lectures say that we can wait for up to 6 months, 9 months before implant this medication. But till now, according to the guidelines, you should wait 3 months only on optimal medical therapy to assess the ejection fraction and decide to implant ICD as a primary. I think we still need more investigations. I'm a electrophysiologist. I believe in ICDs.
My question is more the comments. Professor Abdelhamid knows that the Heart Failure Association of the ESC is completing one of the biggest survey ever on the treatment of heart failure, including the devices. So what we know, that devices are underused all over the Europe.
Yeah.
So we need at least twice number of devices as we are implanting now. Could you give us the insight how that happens and how this is in Egypt? Do you need more devices? Is the implantation enough for the patient who has the indication, or we need to do much more than we do now, talking to the legislation and talking to the sick funds?
The situation here in Egypt, it's like Europe actually, and in Africa, it's more worse. The ICDs is not available for all citizens. The coverage or the insurance for coverage of ICDs, it is up till now still limited. We actually implant all patients who has a secondary prevention cause for ICD, but as regards the primary, our preference first for the ischemic patient, because ICD in the ischemic patient, it's proven, and even in these trials, the ischemic patient is out of the scope because of the nature of the progression of ischemia and the progression of the scars and fibrosis and the triggering activity which is initiated by the ischemia itself. But I think we need to spread the ICD as a primary prevention, because on my personal level, we have bad conditions with our patients who implanting CRT by pacing, for example, and they die suddenly after 3 years from sudden cardiac death, although they improved and their ejection fraction is improved. We have many cases like this. So I think we need to risk stratify more accurate ways for risk stratification for these patients to identify who needs actually ICDs and who doesn't need it.
Yes.
Okay, thank once again for an excellent lecture, inspiring.
Thank you.
Yes,
Thank you so much.
we know that excellent, and we all know that you are expert invasive electrophysiologist, and that's why you end your presentation with very slide.
Yes, I should.
Preparing for ICD recommendation in patients with heart failure. Thank you very much. Next, we can call Professor Dr.
Thank you.
Muhammad Hassan. I think his presentation about this debate. Dr. Muhammad Hassan, professor of cardiology in Cairo University, he will talk about the ICD for patients with heart failure. It's very important debate, and you see from the start, Professor Lamia prepared for his presentation. Okay.
Bismillah ar-Rahman ar-Rahim. So I think in my presentation, I'll try to answer a really important question. There is some debates in this field. So is ICD mandatory for patients with HFrEF even if the ejection fraction improved or not? We know that ICD is an integral part of the management of patients with heart failure with reduced ejection fraction, either for secondary prevention of sudden cardiac death and ventricular arrhythmias. As reported here, ICD is associated with near 28% reduction in total mortality, almost entirely due to reduction of sudden cardiac death and arrhythmic death. It's associated with near 50% reduction of arrhythmic death in patients with heart failure with reduced ejection fraction, and also for primary prevention of sudden cardiac death in patients with both non-ischemic and ischemic cardiomyopathy if they are symptomatic despite of optimal medical treatment for at least 3 months, and ICD lead to near 23% reduction of total mortality as demonstrated here in the SSD HEFT trial. And this mortality reduction has been recently also supported by large contemporary prospective registries like the European CERT ICD registry, which included more than 2,000 patients with ischemic cardiomyopathy and or dilated non-ischemic cardiomyopathy with ejection fraction less than 35%. And you can see here in the graph that ICD reduced significantly the total mortality compared to the control group with around 27% reduction of total mortality. And in the subgroup analysis, actually elderly patients, diabetics, and women are associated with less survival benefit compared to the other subgroups. However, now there is some challenges in the field of non-ischemic cardiomyopathy generated by the Danish study, which demonstrated that the survival benefit in non-ischemic cardiomyopathy is less clear and lower than those patients with ischemic cardiomyopathy. But what do the guidelines say? The recent 2022 guidelines for management of ventricular arrhythmias and sudden cardiac death gives definitely class 1 recommendation to put an ICD for secondary prevention for patients with documented VF or hemodynamically unstable ventricular tachycardia in absence of reversible cause, and also in patients with expected survival with good quality of life more than 1 year. For primary prevention for ischemic cardiomyopathy patients and coronary artery disease, there is a clear class 1 recommendation to put ICD if the patient is symptomatic class 2 or more with ejection fraction less than 35%. If the patient is asymptomatic with class 1 and the ejection fraction is less than 30%, there is a class 2A recommendation to put ICD in those patients. So even if the patient is asymptomatic, this patient has a risk for sudden cardiac death, and there is a class 2A recommendation to put ICD in ischemic cardiomyopathy patients with ejection fraction less than 30%. If the ejection fraction between 36 and 40% and the patient had unexplained syncope or non-sustained VTAC, there is a class 1 recommendation to do EP study, to do programmed electrical stimulation, and if there is inducible sustained monomorphic VT, so there is a class 2A recommendation to put ICD for this patient. The evidence is less for non-ischemic cardiomyopathy. Now there is growing benefit from using CMR to see whether there is a fibrosis or not, but the guidelines now still, there is a class 2A recommendation to put ICD in patients with symptomatic heart failure and ejection fraction less than 35% in patients with non-ischemic cardiomyopathy. If the ejection fraction between 35 and 50% and the patient has 2 or more of these risk factors, also there is a class 2A recommendations to put ICD. So if the patient has 2 or more syncope, late gadolinium enhancement on CMR, inducible sustained monomorphic VT on programmed electric stimulation, and if there is some pathognomonic genetic mutation, especially in the lamin gene associated with increased risk of sudden cardiac death. And due to the known complications of the conventional transvenous ICDs, especially we know the lead fracture, the lead infection, the device infection, and the problems, also the mortality with the lead extraction. Now, subcutaneous ICDs has been introduced as an alternative to transvenous ICD, and it showed that it's non-inferior to transvenous ICD, and now there is a class 2A recommendation to use subcutaneous ICDs as an alternative to transvenous ICD, but importantly, if there is no pacing indication, and also if there is ATB is not needed, because if there is a pacing indication, so you should go for transvenous ICD. So I think the evidence is clear for patients with HFA, either class 1 recommendation in non-ischemic ischemic cardiomyopathy for primary prevention, and class 2A recommendation in non-ischemic cardiomyopathy. But the major debate, what about if the ejection fraction of the patient improved during follow-up, especially at the time of generator replacement? Shall we replace the battery or not? Actually, little data exists regarding how to properly risk stratify those patients with what's called heart failure with improved ejection fraction. And especially that the definition of recovery is varied. Some studies use 35%, some studies use 40%, some studies use 45%, until we have now the universal definition that put that to define heart failure with improved ejection fraction, you should have a baseline ejection fraction less than 40% and 10% improvement or increase of the ejection fraction from baseline to reach a second measurement more than 40%. And they consider complete recovery or full recovery if the ejection fraction improved than 50%, or if the ejection fraction range between 40 and 50, so it's considered partial recovery. And definitely, patients with heart failure with improved ejection fraction has better prognosis compared to HFrEF and even HFpEF. However, still they have higher mortality, higher rate of heart failure hospitalization compared to healthy controls. And this is evident also that if we stopped and discontinued the guideline-directed medical treatment in those patients, as in the TREAD heart failure, the rate of relapse of heart failure reached up to 44% in 6 months, which means that recovery of ejection fraction does not mean resolution of heart failure. Still, there is continued neurohormonal activation, cardiomyocyte injury, oxidative stress. So once you stop the medications, all this lead to more remodeling and again back to heart failure with reduced ejection fraction. That's why the recommendations now is clear in this field. There is a class 1 recommendation not to stop guideline-directed medical treatment in patients with heart failure with improved ejection fraction, even if it's completely asymptomatic, so this patient should receive and should continue the guideline-directed medical treatment. But this is regarding the risk of heart failure. What about the risk of arrhythmia and the risk of sudden cardiac death in those patients? This is data from the NCDR. Actually, it's a very large registry involving more than 26,000 patients who had ICD placed for primary prevention. When they followed this patient, they found that the recovery occurred in around 1/4 of this patient. So we found complete recovery with ejection fraction more than 50% in near 7% of patients, with partial recovery ejection fraction between 35 and 50% in 17%. If we look at the rate, and when they followed these patients on the ICD, the rate of appropriate shocks in patients who with improved ejection fraction or patients with ejection fraction more than 35%, ranging between 5 to 20% during a follow-up period ranging between 2 and 6%. So still, this patient have a risk of ventricular arrhythmias with high rates of appropriate shocks for this patient. So what to do? Shall we replace the generator or not? But currently, there is no guidelines in heart failure with recovered ejection fraction, but the fact that this patient at a high risk of relapse of heart failure, high risk still of sudden cardiac death, 17% of this patient receive appropriate shocks at 3.2 years. So improved ejection fraction during follow-up is not predictive of reduced the risk of sudden death or reduced the benefit of ICD. So I think it's very important to have patient-centered conversation, and sometimes the decision needs to be individualized. We need to balance between, definitely, there is a risk of ventricular arrhythmias and risk of appropriate shocks in those patients, but this should be balanced also against the risk of ICD itself. We know that there is risk up to 0.5% related to the lead device infection, lead extraction, myocardial perforation, also the cost, especially in developing countries and here in Egypt, especially if this device put for primary prevention. And importantly also that still some the data say that up to 25% of the shocks in the ICD patients are inappropriate patients and cause some anxiety and some depression for this patient. So this should be balanced. For example, if we have a patient with heart failure with improved ejection fraction, with history of known ventricular arrhythmias and recent appropriate shock, so definitely this patient will benefit from replacing the generator. However, on the other hand, if you have a patient with ejection fraction more than 50%, non-ischemic cardiomyopathy, did not have appropriate shock before, young patient, and he had some inappropriate shock, so definitely with conversation of this patient, it's better not to replace the generator for those patients. Definitely imaging and biomarkers can help for risk stratification. So CMR scar mass, it's important. If the scar mass is less than 10 grams, this is associated with 100% negative predictive value for appropriate ICD shocks. The presence of mid-wall fibrosis is independently associated with increased risk of ventricular arrhythmias, scar inotropy, and the heterogeneity and variation of the signal intensity even within the scar is associated with increased risk of ventricular arrhythmias, also in addition to biomarkers, the BNP, the ST2, and the galectin-3. So my take-home message is that I think the role of ICD in HFrEF patient is clear, and the evidence actually is clear and from the guidelines, but for heart failure with recovered ejection fraction, it's some debatable. LV ejection fraction recovery occurs in really a major proportion of patients who had ICD placed for primary prevention. Recovery of ejection fraction does not mean resolution of heart failure. Still no guidelines to risk stratify patients with heart failure with improved ejection fraction. The risk definitely is low, but does exist. So we need to balance the risk of ventricular arrhythmias and the appropriate shocks in this patient and the risk of the ICD itself in those patients. So the decisions sometimes need to be individualized in HF and heart failure with improved ejection fraction. Thank you.
Thank you, Professor Muhammad Hassan. Excellent demonstration. You nearly satisfy, I think, us and all of the attendants that ICD is very essential as a secondary prevention. But still, there is some concern, as you mentioned, as a primary prevention. And as mentioned also by the first speaker, Dr. Ayman, there is limitation of the ejection fraction as a parameter, as a primary prevention. Anyhow, I agree with you totally that ICD considered to be individualized approach because it is costly, particularly in limited resource countries, and because it is potential side effects at short and long term, as you mentioned. And as a primary prevention, maybe need imaging, need one more parameters than ejection fraction. That's what I get from your presentation.
This in heart failure with improved ejection fraction, but with reduced ejection fraction in ischemic cardiomyopathy, definitely the evidence is clear. The class 1 recommendations, the ejection fraction is in 35 and symptomatic. So in HF and heart failure with improved ejection fraction, so this needs some discussion with the patient and putting all the information, the risk of the ICD and also the risk of sudden cardiac death still exists in those patients.
I think this will support also what you said, because if improved ejection fraction during the follow-up in the patient prescribed ICD as a secondary prevention, he will surely get benefit if you continue this ICD. Thank you.
Thank you so much, Professor Muhammad, for this excellent presentation. So for the sake of time, we have online Professor Marco Metra. Professor Marco, did you hear us?
Yes.
Yeah, Professor Marco is current president of the Heart Failure Association, ESC, and he is a professor and the chairman of cardiology department, Brescia University, Italy. And he's also the chief editor-in-chief of the European Journal of Heart Failure. Thank you so much, Professor Marco, for joining us. We are missing you here in person, but we know that your agenda is very busy, but
yes.
Thank you for joining us today.
And yes, and thank you. Can you hear me? Yeah. Okay. Can you hear me? Can you see the screen?
Yeah, we are seeing it.
Okay, that's great.
Good.
And so thank you very much for your invitation. And let me take this occasion to also greet the friend and extremely esteemed and authoritative Giuseppe Rosano, with whom I shared these years and the following also. My topic is worsening heart failure in the 4 pillars here that we will see that may become even 5 or 6. These are my disclosures. So worsening heart failure is an event in the history of the patients with heart failure. And it's unfortunately it's a possibility, but it's intrinsic to the clinical history of the patients with heart failure who are facing episodes of worsening symptoms leading to hospitalization. It has also a major role for outcome. The patients developing worsening heart failure have then a high subsequent mortality. These are the mortality data from for patients hospitalized, and you see that these are survival data, but the mortality rate goes from 20 to 35% in the following year, and it's up to more than 50% in the following 5 years. These are real-world series, and these are the data that we have to deal with. So we put together this paper by the HFA, and I also take the occasion to greet and give my best regards to Professor Magdi Abdelhamid, who has a major role inside the HFA. And we pointed out what happens with worsening heart failure. Worsening heart failure is characterized not only by the need of hospitalization, but it's now clear that it may have a broader significance. And we have patients who have simple worsening of clinical symptoms requiring an intensification of diuretic treatment, or may have emergency department visits as well. And so the settings where the sites where episodes of worsening heart failure occur are multiple, and not only hospitalization, but also emergency department visit and also ambulatory visit. And how the concept of hospitalization may vary was clearly shown during the COVID-19 era, where the number of hospitalizations for heart failure decreased dramatically. But this didn't mean that the patients hadn't a poor outcome and even worse than usual. And so here are results from a retrospective analysis from Paradigm HF trial, showing that the risk of death is increased 5 to 6 fold when the patient is hospitalized for heart failure, but 3 to 4.5 fold when the patient simply has an emergency department visit for heart failure, and again 4 to 5 fold when the patient simply is visited as an outpatient and just as an intensification of diuretic treatment. So, as also shown in this analysis from the ESC heart failure registry, we have patients who have an increase in loop diuretic dose that have an increase in the risk of subsequent major events. And these are the scale of increasing the risk. Of course, the patients at the highest risk are those hospitalized, but also the patients who receive an outpatient IV diuretic treatment are at increased risk, and also the patients in whom simply the dose of oral diuretics is increased are at high risk of mortality. So let's think in this way on worsening heart failure. Now, which can be the treatment and which can be the prevention? The treatment of worsening heart failure is obviously mainly the treatment of congestion, and it's mainly, unfortunately, simply a treatment based on diuretics. And here we have a paper from the French Society of Cardiology showing that the diuretic treatment may just imply an increase in the diuretic dose, or have emergency department IV diuretics, or have the hospitalization. And also in the ESC 2021 guidelines and in the following position paper, we outline the diuretic treatment. We start with a dose which is similar to the dose that the patient was receiving orally, and then we may have either a further increase of the IV diuretic dose of the loop diuretic, which is, let's say, the traditional strategy, or we may go straightly to the addition of another diuretic that, according to recent trials, may be acetazolamide, maybe metolazone, maybe a thiazide diuretic, and maybe also an SGLT2 inhibitor considered as its action on congestion. We will see. And this is the strategy that we have to deal with for treatment of the patients with worsening heart failure. Then there is the big chapter of prevention, which is really the heart of the matter, because we have to use this episode of decompensation as a way to optimize oral medical treatment and optimize the administration of those drugs that can improve the outcome of the patients. And this includes, of course, the four pillars of treatment of heart failure: ARNI or ACE inhibitors, beta blockers, MRA antagonists, and SGLT2 inhibitors. Here we have the results with ARNI compared to ACE inhibitors. And actually, there is an improvement in the outcome with sacubitril/valsartan compared with enalapril or valsartan. But this is significant only up to 60% of ejection fraction. SGLT inhibitors have a beneficial effect on the outcome, as well known. And this applies also to the patients with worsening heart failure. Actually, this was the first trial published with this regard, to which I participated, with sotagliflozin versus placebo, which is a non-selective SGLT inhibitor. And the study was done in patients with diabetes and hospitalized for heart failure. And you see this large reduction in major cardiovascular events. And you see that the Kaplan-Meier curves started to diverge very early. The beneficial effects of DAPA or empagliflozin were then shown by major clinical trials. And this analysis from the liver shows that also the patients with a recent heart failure hospitalization have a significant reduction actually of major events. Then we all know that empagliflozin was also used in patients with acute heart failure and improved a composite endpoint, including quality of life, heart failure rehospitalizations, and mortality. And this was also associated with a reduction in congestion, as shown by a 1.5 kilo decrease in the body weight and with hemoconcentration because of the diuresis. Moving to different classes of drugs, we have IV ferric carboxymaltose or also the risomaltose shown to reduce events in patients with iron deficiency and worsening heart failure. And last but not least, we have to recall vericiguat, which was administered in Victoria in a context of patients with worsening heart failure, as shown by this very high risk of events that the patients had at 1 year. More than 30% of patients had a major event at 1 year, and with a very significant absolute risk reduction. Vericiguat has some advantages compared to neurohormonal antagonists, which are, however, also indicated in patients with reduced or mildly reduced ejection fraction. It has a very mild effect on systolic blood pressure. You see here that it was transient and significant only in elderly subjects, and has an effect that has been tested in patients also with a very low glomerular filtration rate. We have attended the magistral speech by Petar Seferovic before, and with regards of patients with CKD. And you see here that in Victoria, vericiguat was given to as low as 15 ml per minute per square meter of eGFR, and you see here that the effect was significant irrespective of baseline glomerular filtration rate. So also, and I may say above all, for the patients with worsening heart failure, optimal medical treatment is a treatment based on the combination of different drugs, and you see here that the additive benefit of vericiguat to SGLT2 inhibitors and triple therapy with neurohormonal antagonists. Of course, telemedicine will have also a major role in these patients, and with this in mind, these are my take-home messages. Worsening heart failure is a frequent event, not only defined by the hospitalization. It is associated with a marked increase in the risk of poor outcomes. Treatment is that of acute decompensated heart failure, but prevention may be based on quintuple therapy, if not 6, in the patients with iron deficiency. Thank you for your attention.
Thank you so much, Professor Metra, for this wonderful presentation. I have one question regarding remote monitoring and the role of remote monitoring to avoid worsening heart failure and to adjust the medications properly before hospitalization. So what do you think about this?
It's very important. Unfortunately, we need to get used to it, and at least in my reality, still not so widespread. And of course, the more you deal with a large territory, with a large area, the more is important to use telemonitoring. And the bottom line is that we have also the strong HF trial that I will mention when talking about natriuretic peptides later. I mean, if you are able to talk with the patient, monitor his body weight and systolic blood pressure, and have his laboratory exams, which are serum creatinine, electrolytes, and NT-proBNP as a measurement of congestion, you may really deal with the patient and optimize medical treatment and prevent relapses of worsening heart failure, I think. Of course, I don't know the situation in Egypt. We know that we have also invasive telemonitoring with the CardioMEM device, which is even better, although more expensive. But I think that it will be used more and more.
Marco, Petar, A great talk. Thank you very much. You are tackling one of the most important part of the heart failure spectrum. Do you think that appropriate and early use of SGLT2 inhibitors will help the patient in this vulnerable period to have the shorter recovery period and to be more prone to the early recovery?
Yes, absolutely. Thank you for your question, because actually SGLT2 inhibitors are the easiest drugs to give for heart failure to date, because it's monotherapy, single dose, and devoid of any hypotensive or bradycardic effect, and kidney function may improve in the long term. So they are very easy to give, and also in the context of patients hospitalized or recently hospitalized, they have improved outcome. So the easiest option.
Okay, thank you so much, Professor Metra, for joining us today. And I think you have another presentation, another session. We appreciate the collaboration between the Egyptian Society of Cardiology and the HFA. So thanks for Professor Marco Metra, Professor Giuseppe Rusano, Professor Peter Sirovic for joining us in this elegant session. Thank you so much.